is about, it takes about 20 minutes for the anesthesiologist to get there, depending on the time of day. So if it's 2:30 in the morning, it could take a little bit longer. They know it's not an emergency, so they're going to actually maybe brush their teeth before they get in the car, that sort of thing. So you need to expect about 20 to 30 minutes after you ask for it. If they're already in-house and they're right next door finishing one up, it's your lucky day, because he'll be over there, he or she will be over there in 5 minutes. And I want to say this, I'm going to say it over and over, the contractions that you have from the time that you decide to get the epidural to the time that you actually get the relief from the pain are the hardest contractions you'll experience in your labor. I don't care what stage you're at. And the reason is you have, and I don't need to probably say this, but you've decided that you're going to get that relief. I'm over this. I was over it 2 hours ago, and mentally I'm just not there anymore. So birth partners, this is when your job is really, really key. So she has decided to get the epidural. You have determined that this is the best thing to do for the birth plan, and you move forward with that. Your job now is to help her get through those next 5 to 8 to 12 contractions that's going to happen, because her mind just goes somewhere else and they're the worst. So at that point, you get down on her level and you just kind of count through the contractions, or you just do what you've been doing, but more. Your presence needs to be really gigantic in the room at that time. And you help her with them, whether it's through toning, which we'll talk about, or the breathing, or whatever needs to be done, distraction, get her in the bath, because it can take a little while for the anesthesiologist to get there. And those are, so your job turns into a pretty important job. And we'll talk about more about that next week, and with Alethea and how you interact with, how dads interact. Because a lot of my class so far has been really mom heavy, but it'll be coming. Your turn is coming. The way it's administered, the anesthesiologist walks in, they need to give you at least a bag of fluids, because it can mess with your blood pressure a little bit. So they give you a bag of fluids so that you're really hydrated. You sit on the edge of the bed, and you wrap a pillow around your bellies. You hug a pillow. Dad is right here in front, so you don't need to be back there watching any of that stuff. Don't you worry. I wouldn't recommend it. And so you're giving her moral support, because every woman's biggest fear is having contraction while they're getting the needle placed, right? Because what happens if you have to move and you've been moving through your contraction? It may not be your fear now, but right now, I mean, now it is. But, you know, in the labor and delivery, I have, every mama will say, how do I hold still while I'm getting an epidural? I don't want to mess up this needle thing. And you just do. So, but dads, your job at that point is to help her know that she will stay still. So you get the epidural, the doctor will get their whole setup right there, and then he or she will make a nice big swath of iodine around the site, and then they'll put a sterile plastic shield in the back that has the hole right there. And they're talking through it the whole time, depending on who it is, but they'll talk you through it. They're very friendly. And the first thing they do, and you're holding like this, and they're pushing, and they're finding just the right spot, and he says, or she says, tell me if you're going to have a contraction so I can know. And so they will find the right spot, and then what they'll do is they'll take a little anesthetic, like a numbing, you'll give a little numbing shot, the first thing, so that you don't actually feel the needle going in. So you get almost like a topical, like you're getting your mouth worked on. And that numbs the skin around it. And then he'll poke you a few times and say, do you feel this? Do you feel this? And you say no or yes. And then once the anesthesiologist knows that you're numb, they then insert a catheter. So it's not actually a needle. It's about this long, and it's a thin, hollow tube. And they insert that right there at the right spot. And then they take their tube that's going to administer the medicine, and they thread it through. So what's actually there is the tube, not the catheter. So obviously he removes the catheter, and then he tapes the tube into place, okay? And that is it. So within about 5 minutes of that, you will start to feel relief with those contractions, and your legs start to feel really heavy, and the whole tone of the room changes, and we're going to talk about that in a little bit. So that's the procedure. They will talk you through it. Now, if you do have a contraction, it's amazing to me how well people can stay still. And basically, there's only one tiny point at which it's really important that that he doesn't miss. And he'll say, if you're about to have a contraction, just let me know, and he'll wait, or she'll wait. So it's not a huge deal. But I know that's everyone's fear when they start to play the whole thing out in their mind. What can then happen is, again, you're all taped up, you get back on the bed, and you can administer the dose. But they have a limit on it, but there's a little button push. I actually think it's make-believe, but you know, a little button that you can push to get more of the drug if you're feeling it. They have gotten really good at just doing a light dose of an epidural so that you can still feel the urge to push, typically. It's not like it was before, but you can sleep through the contractions and get some rest. What else do I want to say about that real quick? Okay, so in here, I did include a picture of where the epidural goes. It does not go all the way into the spinal column, I guess you want to call it. It doesn't even go as far as if you have a spinal block. Okay, it's this picture here. Where does the needle go? So if I were to go in and have a 4th C-section, Lord help me, I would go in and get a spinal block, and that is a one single time of administration of medicine. They knock me out. I do not feel anything. Now an epidural is a continuous flow of medication at a lower intensity. So that's how that works.
Actually, they could put those in your legs. When I had ankle surgery, I think they put one in my leg.
Yeah?
My leg was numb for
really?
like 2 days or whatever it was.
Nerve block.
Or nerve block, that's okay.
Okay. Okay, so any questions on the epidural right now? I'm going to go into it a little bit more, but about how it's administered. Now, okay, let's move on. It requires continuous monitoring afterwards, all right? So you will be on the bed, monitored, blood pressure, baby's heart rate, and your contractions will be monitored. You're not getting up. You get, this is where all those tubes come in, you get a catheter at this point, and because you're not getting up to go pee, all right? So that's one of the tubes that gets placed in there.
Only if you have an epidural.
Only if you have an epidural, yes. So yes, if you have that internal monitor with the Pitocin, that's the only tube that's coming in. Yeah. And then, so when would we get an epidural? I would not recommend it for early labor. It's generally not recommended. The doctors are going to be real excited for you to get an epidural when you're only 2 or 3 centimeters dilated. There's a couple reasons for this, because 1, it can slow down labor. 2, you can handle, first stage labor. Every single one in this room can handle first stage labor. It's when it gets harder, and that's when you want to fall back on epidural. It can wear off. So it can become less and less effective. So you want it the most effective when you are in your most pain, which is transition. And there has been some research, typically, that unlike morphine, it does not cross the blood-brain barrier, or into the placenta. So babies don't get that epidural because it's simply in your spine and then lower. It's not going through your blood. When I look at that really critically, I think if anything is going in my spine, it's probably going through my blood system. But it is not, so there can be, the longer you have it, there can be, I believe that the baby can get some of the residual medicine that the morphine, or that the epidural gives you. So I want you to wait as long as possible, okay? And then we go to maintenance. So we get an epidural. Basically, you have that tube stuck to you, and you're bed bound. And you have to move from side to side, because what the epidural medicine does is it pools on one side of your body, whichever is laying lowest, and then the other side. So the nurses will move you side to side. So even if finally Melina gets to sleep, she's not getting great sleep because the nurses every 2 hours are coming in to make sure that she's moving side to side. So and sometimes you're on your right side, left side, and baby loves this. Heart rate's great, all that stuff. You move to the right side because they need to move you on this side. Baby heart rate kind of drops. You're crunching the cord or something like that, they don't like it, you're going to have to move to the other side again. So there's a lot of shuffling, all right, with that. And then aftercare, it's really easy to remove it. I don't even know when they do it. when labor and delivery, when I'm there, I think they just quickly kind of take it and it's gone, okay? So it's pretty easy aftercare. Now the risks of having an epidural, because it comes to you, I tell you, sometimes it doesn't take away all the pain. Sometimes it doesn't work at all. So if you think those 20 minutes of contractions were hard after you decided to get an epidural, try deciding one and not having it and keep waiting for it to work, and it still doesn't work. So that can be a real mind screw if you're thinking that's gonna work. Even worse than it not working at all is it just working on one side of your body, which I've heard of, I've never seen. And I would definitely tell the anesthesiologist as soon as possible because they can try to replace it, but sometimes your body is just made that way where it only works on one side. So here you have relief on one side. I don't feel anything here, but I can feel absolutely everything here. Oh, and by the way, I can't get up, I can't take a bath, I can't really move. So that is definitely a risk and a reason why I would consider it. Not real common.
Is there a time, like too far into your labor, that they won't do an epidural?
No. That's an
They'll do it all the way.
They will do it.
Okay.
My urge to you is even if the anesthesiologist dragged himself out of bed at 4 o'clock in the morning, ask that you get checked right before you get there and to
See how far you are.
To see how far you are. Because the people who brought in the dried cherries and the, all that stuff, she got there, labor was great, she walked around the hospital for an hour, she got into bed, things really started moving, she wanted an epidural, she was 9 centimeters dilated, by the time the anesthesiologist got there, she was 10 centimeters dilated, she still had it. She didn't need it, she was through the hard part.
Exactly.
So if you're feeling any urge to push, or any of that real pressure down there, don't get it done, even if that anesthesiologist has walked in. That's your right to say, actually, I don't want this.
Okay.
And me, probably. Don't do that. But no, there is not. I've not ever seen an anesthesiologist or doctor turn anyone away because they're too far along.
Okay.
Okay? There's not a risk of that. Now I say that, and my next, people are going to come back and say, actually, I didn't get my butt.